Gracias, Pepe. Efectivamente, en algunos momentos, a los que somos clínicos y no estamos acostumbrados a esta alta tecnología, nos ha parecido estar en la guerra de las galaxias. Siguiendo con la analogía, viene la parte más clínica de esta mesa y es, siguiendo con la analogía, diríamos, la parte oscura de la fuerza. Y para hablarnos de la parte oscura de la fuerza, tenemos con nosotros al doctor REISS. Doctor Peter REISS no necesita presentaciones, extraordinariamente conocido, pero simplemente a modo de pequeños detalles, él es profesor de la Universidad de Ámsterdam, trabaja en el Academic Medical Center de la misma ciudad, tiene una extensa producción científica que va dirigida al tema que hoy nos va a presentar, son las comorbilidades en el contexto del paciente VIH. The stage is yours, Peter, when you want.
Thank you very much, Per. I hope you weren't exaggerating. And I hope you also forgive me for putting in a picture in my opening slide of the stadium of Real Madrid, where I had the pleasure to be invited for dinner last night, and it was a spectacular venue. So thanks again for the hosts. Thanks also for inviting me to talk about this topic. And it's actually interesting to listen to Pepe's talk, because I think some of the knowledge that you gain in looking for a functional cure may also yield relevant information for the issues that I will discuss. So these are my disclosures. So if we talk about aging, one of the things to realize, and I'm sure all of the clinicians in the audience do so, is that we're actually lucky enough to see our patients age in the current era. This is a picture from the Netherlands where we follow, in the Athena cohort, follow all the people with HIV in care in the Netherlands, and you see the change in age distribution over the years. And at the moment, these are data which we recently presented just a few weeks ago, looking at our current data set. 42% of our patients in care are older than 50, and 14% are older than 60. And this is a remarkable change compared to what we saw in the beginning of the epidemic. Of course, as we all age, we become prone to developing other comorbidities. This is a slide data from the Swiss HIV cohort study, where they, a couple of years ago, looked at the numbers of comorbidities in their patients depending on age, and as you can clearly see, the number of comorbidities rises with age. And not surprisingly, of course, also this is accompanied by an increase in co-medication, which makes life more complicated, especially because of potential drug-drug interactions. Based on the data that we have in the Netherlands, Michaela Smit from the Imperial College Group of Tim Hallett in London has modeled what would be expected to happen in the Netherlands in the coming years. And what she found in a recently published report in Lancet Infectious Disease is that the median age of our patients will change from approximately 44 years to 57 years in 2030, and the proportion of patients over 60 will increase from 8% to 39%. So these issues with time are going to become even more relevant. There are many chronic diseases associated with aging that have been shown to be more common in those with HIV. And this is true even when you adjust for ART use and when you adjust for traditional lifestyle-related risk factors. And that's really the basis why people have started to ask the question whether HIV-positive patients may age more quickly than HIV-uninfected persons. And as I'll have convinced you at the end of the talk, I don't really think we have the answer to this question yet. Now, the drivers that you can think of that are maybe driving this increased comorbidity burden in HIV are very important, I would say, are host-related, lifestyle-related factors, and of course potential genetic factors. ART toxicity plays a role, and an aspect that has really become very much to the forefront of our thinking in the last few years, especially after the release of the SMART trial results, and now more recently with the START results, is that there may be persistent immune dysregulation and inflammation in treated HIV disease, something that Pepe already alluded to. And we know that inflammation is important in natural aging, and that's why people think it may also be important and possibly in an accentuated way in the context of HIV, and ultimately result in a higher burden of clinical chronic comorbidity. And of course, all of this is superimposed on the natural aging that occurs anyway. So in order to get because this was all very much speculative, and a couple of years ago we decided to dive into this more deeply and set up this cohort study, the so-called HIV cohort study in Amsterdam, where we look at the prevalence and incidence of these comorbidities, decided to focus on people over 45 years of age, started in October 2010. And what we do is compare a group of HIV-1 infected people that we recruit from the HIV clinic at my own hospital, and we have a comparative group of HIV uninfected persons that we recruit at the Municipal Health Service in the city of Amsterdam, something that we're doing based on long-standing experience with an Amsterdam cohort study on HIV and AIDS that was started in the mid-1980s. And which is still ongoing, and in fact, some of the people in our current HIV cohort are actually also participants in that older Amsterdam cohort study. Now here you see some of the characteristics of these two groups at baseline, the HIV uninfected in the left and the HIV positives on the right. You see that most of the people are male, which is really the reflection of the HIV epidemic in Amsterdam. Their current median age is in their early 50s. The majority is Dutch, and the majority are men who have sex with men. If you look at the characteristics in the HIV-infected group, this is a group of people that have been infected with HIV for a prolonged period of time, had a relatively low CD4 nadir around 180, but currently have a CD4 count around 565, so good recovery on treatment, and a very large majority of the cohort is on suppressive antiretroviral treatment and has been on treatment for quite a long time. If we look at comorbidity risk factors, we see, as has been seen in other studies, that the HIV-positive people smoke more frequently than the HIV uninfected people, whereas severe alcohol use is a little bit more frequent in the HIV uninfected. And of course, this is Amsterdam, so if you look at recreational drug use, you can see that there is a fair amount of such drug use in both groups, with some differences, but with notably ecstasy use being more common in the HIV uninfected. The BMI is slightly higher in those slightly lower in those who are HIV positive, and blood pressure is slightly higher in the ones that are HIV positive. When we did our first analysis, we found indeed that there were significantly more comorbidities in the group with HIV. And the types of comorbidities that we found, generally speaking, we found that cardiovascular, both cardiovascular and peripheral arterial disease were significantly more common in those with HIV. For the other comorbidities, you'll see that it doesn't reach statistical significance as yet, but what is quite striking is that numerically, each of the comorbidities that we look at is more frequent in those with HIV. If you then look at the distribution of the numbers of comorbidities, so what this slide shows is by age on the x-axis, so age categories going from younger age to older age from left to right, with the HIV infected on the left and the HIV uninfected on the right. You can see that with age, of course, there's an increase as expected in the numbers of comorbidities. Possibly there is a hint that the distribution of comorbidities in the HIV-infected group who is younger may be similar to the HIV uninfected who are slightly older, potentially linking this to premature aging, but I think it's very dangerous to conclude that from, or you shouldn't conclude that from this cross-sectional analysis. But I think what is most striking is if you concentrate on the red color, which are those people who have 3 or more comorbidities, that's clearly, so multimorbidity is clearly more common, and especially in the older age category, but also to some extent in the younger age groups, in those with HIV. And I think that's really a reflection of what most of us see in the clinic nowadays, people with multiple other diseases apart from their HIV. Now, if we then focus on a number of the specific comorbidities, this is a slide about hypertension. We find that hypertension measured in a standardized manner is more common in those with HIV. And when we analyze the risk factors, we find, of course, age as a risk factor. We also find patients of African descent to be at higher risk. Of course, people with a family history, and then although in the initial steps of the model, HIV infection by itself was associated, this disappeared when we inserted a higher waist-to-hip ratio into the model. And interestingly enough, if we concentrated on the HIV-infected subgroup only, in that case, in the first step of the model, prior exposure to stavudine, which of course is something from the distant past in these patients, was associated with a higher risk of hypertension, but that effect disappeared once we corrected for waist-to-hip ratio. And interestingly enough, this is not shown on the slide, this was driven by both a reduced hip circumference as well as an increased waist circumference, suggesting that stavudine-associated lipoatrophy in particular and lipodystrophy more generally might be a driver for an increased risk of hypertension, despite the fact that this is a group of people who have been exposed to stavudine in the past and of course haven't been on stavudine anymore for a longer period of time. Arterial stiffness is something that we look at by measuring pulse wave velocity, and what we find is that people with HIV have a higher pulse wave velocity, which is a reflection of stiffer arteries, and here the risk factors again are known risk factors such as age, smoking, high blood pressure, both a lower end as well as an extremely higher end BMI, lower HDL cholesterol, and higher CRP as a reflection of inflammation. And in the HIV-infected participants, something that again comes back in many of our analyses, having experienced a very low nadir CD4 count, so progressive HIV disease was also found to be a risk factor. Turning to bone, osteopenia and osteoporosis, like in different studies, different other studies, we find a higher prevalence of osteopenia and osteoporosis in the HIV positives, and here risk factors are age, smoking, and importantly, especially I think for a country like Spain, chronic hepatitis C. And in the HIV-infected participants, again, interestingly here, we find evidence for past events to be important because we found that people not only who have experienced prior severe immune deficiency, but also people who in the past or currently have experienced lower body weight, for instance, presumably from HIV wasting syndrome, may still be at increased risk of osteopenia nowadays, so many years later. And here you see a slide looking at the distribution of osteopenia and osteoporosis in different bone locations, lumbar spine, femoral neck, and total hip. And as you can see, it's slightly more pronounced in the lumbar spine area than in the other bone areas, but it's present in all three, something again that has been seen in other studies, including in clinical trials. Frailty is something that we measure by using the Fried frailty phenotype and the assessment for that. And again, we find more pre-frailty as well as frailty in the HIV positives with a number of risk factors. And interestingly here, there's also an effect of body composition with a higher waist-to-hip ratio being a risk factor, something that has recently also been observed in studies in the general population. And again, chronic hepatitis C came out as a risk factor. Again, and that's something why I'm stressing it, events from the past, having experienced a low BMI in the past, also in the HIV positive group was found to be associated with frailty. So having been exposed to advanced HIV disease, potentially associated with wasting and a reduced BMI, may still leave scars many years later on in the sense of development of frailty. Here you see that the presence of a higher prevalence of frailty and pre-frailty was present in the HIV-positive group compared to the HIV-infected group, regardless of which age band we looked at. And as I said, we're using the Fried frailty phenotype, which looks at these 5 factors listed on this slide, and we found that it wasn't like any single of these 5 factors that was more prevalent in those with HIV, but really that all of the 5 factors that you need to assess in order to measure frailty were driving the increased overall prevalence. Neurocognitive impairment, and this is something that we published last year, or no, earlier this year in AIDS, is something that we looked at, but I think why I'm showing this slide is that the prevalence of neurocognitive impairment, which I'm sure you know from the literature, the published literature shows a very wide range of percent point prevalence. In fact, we found in this study that this is very much dependent on how you actually assess cognitive impairment. So when you use the Frascati criteria, you'll find that it's not a very sensitive method because you find a very high prevalence in the HIV uninfected group as well, whereas in the Frascati criteria, when you use them modified by Magnus Gieslen in Göteborg, you find a very much reduced prevalence. And we used the so-called multivariate normative comparison, which is a method that our neuropsychologists at the AMC have developed for looking at other diseases, and that they find to be much more reliable. We find a prevalence in the HIV positive group, which is 17%. And there is a difference with the HIV uninfected group, but the degree of difference is much smaller than what has been reported previously. And something that we haven't yet published, but if we look at the risk factors for cognitive impairment, we find that other comorbidities are important, depressive symptoms are important, and something that also clearly came out is cannabis use was also a risk factor. And again, like in some of the other analysis that I showed you, in the HIV-infected participants, having experienced a low nadir CD4 count was a risk factor, something that has also been reported from the Charter study in the US. So if we all summarize all these specific comorbidities, and I've tried to do that on this slide, we find that traditional risk factors, notably older age, as expected, came out. African descent for some of the comorbidities, but not for the others, plays a role. Hepatitis C for some plays a role. Smoking is a very important one. Body composition, interestingly enough, plays a role in many of these. And what I've called old-fashioned ART, which for some, I haven't talked about exposure to high-dose ritonavir, which we used in the past. For some of these came out as a risk factor. And what I've told you is about stavudine exposure in the link with hypertension. And then in some cases, inflammation comes out as well, and immune deficiency also plays a major role. So there is I think what I want to stress with this slide is that there is a pattern for some of these risk factors, but that it's also quite dangerous to generalize, and that for specific comorbidities, you may find different risk factors. Now, we're following the cohort participants over the long term, and hopefully we'll have sufficient funding to continue that over the years, because I think that's going to be essential. This is a picture after 2 years of follow-up, again, counting the number of comorbidities. So over a 2-year period, we don't see much change. But what we still see, of course, is this pattern of multimorbidity, which to me clinically is really the most concerning. So getting back to the disease drivers, sorry about that, and talking about inflammation, I think the START trial that I'm sure you're all aware of and familiar with has a sub-study where they're going to be looking at inflammatory markers and should hopefully yield a lot of information about what the role of inflammation is in driving this excess risk of comorbidity, non-AIDS comorbidity in people who start ART in a delayed manner. I'll skip this for time. Host factors, I think I always stress in my talk that these are important because that's really the primary thing that we as clinicians can modify. And this is a slide from the ART cohort collaboration published there quite recently, which clearly shows that as people with HIV age, they clearly lose more life years due to smoking, something like smoking, than they do to HIV. So concentrating our efforts on smoking cessation, I think, is very, very important. With respect to ART toxicity, I'll go quickly. Of course, we all know as clinicians that even with our current ART, there are still some toxicities which may affect end organ dysfunction and therefore contribute to comorbidity. This is a slide again from our Athena cohort, looking at the last 5 years and looking at tenofovir emtricitabine-based regimens with different third drugs added to that. And as you move from the left to the right, you can see that with the more modern regimens, fewer patients need to modify their regimen because of toxicity in the first year of treatment. And I want to stress this is the first year of treatment, so this isn't showing you anything about longer-term toxicity. But our drugs are becoming safer. And of course, we know from the tenofovir to tenofovir alafenamide switch trials, such as this one, that in fact you can get an improvement, in this case on bone, and also on renal tubular parameters. So again, drugs are becoming increasingly safer and over time and in the future may contribute less to these chronic comorbidity burdens that we see. So coming back to the question whether HIV positive persons in fact age faster than HIV uninfected persons. In other words, whether apart from the topics that I've addressed, whether HIV and ART in addition may interact with biological aging and the normal factors underlying aging. And this is a very tough question to answer. I'm showing this slide, which is actually a review from a group here in Madrid, which reviewed in Cell, I think it was, I forgot to put the reference on the bottom, reviewed the biological mechanisms that people that are working in the aging field are thought to underlie the process of biological aging. And if you dive into the literature, you'll find a number of in vitro and in some cases ex vivo studies that HIV by itself or ART or certain ART components as well as a combination of these factors may in fact interact with many of these mechanisms that are thought to underlie aging. And that, I think, provides a biological rationale why studying these mechanisms in the context of HIV may be relevant. And that's one of the reasons why, superimposed on our HIV cohort study, we were lucky enough to start the so-called COBRA project, and COBRA stands for Comorbidity in Relation to AIDS, which is a project that was funded in the last round of the EU FP7 program. And the slide really shows exactly the three things that we're trying to address with COBRA. We want to further establish the link between HIV and these comorbidities, and for that purpose we're using the cohort study that we've set up in Amsterdam, but we're linking that to a cohort study of a similar nature that is running in the UK, the so-called POPPY cohort. And we have the opportunity now, with the biobank that we have established and that our colleagues in the UK are establishing, to really look at a wide range of biomarkers. And also another aspect that we've been able to do is focus much more on the cognitive impairment side, for instance, through being able to do a large variety of neuroimaging studies. A second aspect that we've built in is an animal model, and this is a humanized immune system mouse model that we have at the AMC, because the call from the EU called for establishing causative links between HIV and these other diseases, and of course a causative link is something that is very hard or impossible to establish from a cohort study. And then as a third step, we try to clarify the pathogenic mechanisms that are underlying the link between HIV and these diseases. We have 12 consortium partners, as is usual in these EU consortia, from a variety of countries, and you see them listed here and the names of the institutions. And I think, going back, an important aspect of this program is that what we've managed to do is really bring researchers in the HIV field together with researchers in Europe working on aging. And hopefully that will lead to a productive collaboration. Now, as far as the mice is concerned, that has created, probably for the mice more than for us, but it has created numerous headaches because we set out to try and administer combination triple therapy to these mice for 6 months. And I can tell you this has not been an easy task, but if you concentrate on the panel on the left of the slide, lower left part of the slide, it actually shows you the viral load course in our last group of mice whom we've been able to put on triple therapy for 6 months, and you can see that we've managed to now create a situation where we are able to suppress HIV in these mice for a prolonged period of time. So the next step will of course be to look in these mice at numerous metabolic outcomes, but also, for instance, looking at bone health, looking at aging markers that we can do both in the human cohorts and to some extent also in the mice. So this is really early stages, but at least we've reached the stage after approximately 2 years to be able to generate HIV infection in these mice and expose them to triple therapy for a long period of time. And of course, what we can do in the mice is distinguish the effect of exposure to triple therapy in the absence of HIV, as well as to just HIV, as well as to the combination of the two. I've already mentioned the collaboration with the POPI cohort in the UK. These are I'll skip that for time, but these are the many people that we collaborate with, and as is usual, of course, in these EU programs, it's divided up into work packages, and there is a very productive collaboration between the work packages. I've put in this slide because I think one of the interesting features in the COBRA collaboration is that we collaborate with people in the aging field from another EU program called the MARC-AGE program, and MARC-AGE was set up to establish biomarkers of human aging. And the MARC-AGE group now claims that they have established a panel of biomarkers which provides an algorithm to actually determine biological age. So very soon, we're hoping to validate that panel in the context of our COBRA collaboration and see how this performs in the context of HIV, and of course how it compares between HIV infected and uninfected individuals. Now for the last part, looking towards the future, again a slide from Michaela Smith at the Imperial College, how this is going to project in the future. And what her model predicts is that by 2030, 28% of people in the Netherlands, of our HIV-infected population in the Netherlands, will be suffering from 3 or more comorbidities. And in her model, the one comorbidity that really stands out is cardiovascular disease, which I think fits quite nicely with data elsewhere in the world. Now, of course, this is not just something that is likely to happen in the Western world, in the northern part of the hemisphere, but also in the south, where, of course, the burden with HIV is much stronger. And in a continent like Africa, this is also superimposed. This is a slide from the Global Burden of Disease study. This is superimposed on the fact that, especially if you look in southern Africa, there is already an ongoing epidemic of non-communicable disease, such as cardiovascular disease and diabetes, and this is going to intersect with the HIV epidemic. Now, fortunately, I think the database about these non-communicable comorbidities in Africa is still limited, but fortunately, I think studies are clearly increasing in Africa as well, and also in Southeast Asia. So I think we'll see more data coming out in the next few years on these issues, also from other parts of the world. And hopefully things that we learn in our studies, such as the one that we're running in Amsterdam or in the UK, will also yield information that can be applied in studies in Africa or Asia. And in fact, we are trying to enter into some collaborations in trying to do so. So I think in summary and to conclude, I think we find that the burden of various comorbidities is consistently increased in those with HIV. Traditional risk factors play a very important and key role, and that needs to be reflected in our clinical management and care. We find independent associations with HIV infection for some, but not for all comorbidities. So again, stressing that we can't all just simply lump them together. Generally speaking, I think we see that longer time spent at low CD4 counts, rather than overall exposure to ART, generally contributes to greater comorbidity risk. But again, there are differences for certain comorbidities. And of course, early HIV diagnosis and treatment has now definitively been shown to be beneficial in modifying this risk, and exactly through which mechanisms is something that we may be able to tease out through biomarker studies within, for instance, the STAR trial. Persistent inflammation and innate immune activation, generally speaking, but again not consistently, seem to contribute towards the risk. And the pathogenic pathways involving effects on the biology of aging, I think, need further exploration. They may be there, but it could also very well be that we find that there are no effects on the biology of aging. So I think it's too early to draw any conclusions, and hopefully our future work will be able to provide some answers there. And then finally, I'd like to, first of all, thank all our study participants, and second of all the remarkable colleagues and scientists that I am lucky enough to work with. And with that, I thank you for your attention.